I will be available for office hours virtually. Okay. I'm happy to do a FaceTime call. I got a whiteboard downstairs I can draw on, whatever. Okay, all right, so that's VQ mismatch. VQ mismatch is the most common cause of hypoxemia. Why is it the most common cause? Because it covers a ton of stuff. Okay? Your ability to ventilate, your ability to move blood through your lungs, okay? They're highly related to each other. There's a balance. There has to be appropriate blood flow. There has to be appropriate ventilation. Okay? I'll kill somebody.
Don't say that. You do love me a small town.
All right. You guys will be fine. It'll be me they're coming for. No ideas. No ideas. All right. So causes of hypoxemia. Okay. VQ mismatch, shunt. Okay. These are kind of the same thing. Okay. Alveolar hypoventilation. We're not breathing enough. This goes right up into VQ mismatch. Okay. So causes of hypoxemia. Say 1 VQ mismatch. Oh, and before I forget, there was one thing I wanted to tell you guys. Blood gases and blood gas interpretation is now a free-for-all. It can and will show up on any test from now on through the rest of the program. Okay? Your board exams, there's not a single question on your board exams that says, gives you a blood gas and says, what's the interpretation of this blood gas? Okay? Every single question on your board exams is going to expect you to interpret the blood gas and then make an action based off of it. Okay? So, not necessarily yet, but once we get into the point of this class where we start making ventilator changes, okay? I'm gonna give you blood gases, and interpret them, cool. But I'm not gonna ask you for the interpretation. I'm gonna begin to ask you for an action based off of the blood gas. Okay? And it's not as scary as it sounds. CO2 is high, what do we do?
Make it low.
Make it low. How do we do that?
Increase
Increase the minute ventilation, okay? Oxygen's too high, what do we do? PaO2's too high.
Turn it down.
PaO2's too low.
Turn it up. Turn it up.
Okay. Look, you guys are doing it already. I'm telling you. Instead of respiratory therapists, we should just be called pH balancers or something. That sounds stupid, so. All right, so VQ mismatch. And VQ mismatch encompasses shunt, and I would also say alveolar hypoventilation, because look, ventilation's in the dang word, right? Okay. Oh, I always do that just because I get it right ahead of myself. Okay. Look at that, we got slides on VQ mismatch. The balance simply stated. There's more air than blood at the apice. Oh, okay. So here's a little talk about pathophys, okay? And I kind of shied away from this in 117 because everyone was already like, there's more air than blood at the top of your lungs, okay? In the apices, the upper portion of your lungs, okay? More blood than air down at the bases, okay? Why is that?
Gravity.
Just gravity. Gravity, okay? Blood's heavy. Blood weighs as much as water does. How much do you think, so your dishwasher at home, okay? Unless it's your significant other or you, okay? But your standard like 3x3 dishwasher, okay? If you took that dishwasher, okay, that cube, and filled it full of water, how much do you think it would weigh?
A lot.
More than if it wasn't filled.
This is an accurate deduction. What do we think?
A lot.
It's gonna weigh over 2,000 pounds.
Yeah.
Okay. Water is super heavy, 8.3 pounds per gallon. Okay. 1 kilogram per liter. Okay. Which is another reason that the metric system is kind of awesome, right? patient loses 1 kilogram, that means they lost 1 liter of water. It's very easy to compute that. Okay? So blood is super heavy. You got more of it down in the bottom of your lungs than you do up in the top, simply because gravity pulls it to the bottom. Okay? Pathologic VQ mismatch occurs when disease disrupts this balance and hypoxemia results. Okay? I hope that what I did here was easier to understand than these slides. Okay, I feel like Egan's kind of like gets a little too detailed here. Most commonly seen when ventilation is compromised despite adequate blood flow. Okay, so do we usually have a low V or a low Q?
No V.
A low V is more common than a low Q. Okay. Okay, obstructive lung diseases are frequent causes. Okay. That's actually a deceptive thing to put on there. I should probably erase that. Okay, so VQ mismatch. The end result is that the patient will have a low PaO2, low arterial oxygen content, and a correspondingly low saturation of arterial O2, or SpO2. Remember, SaO2 and SpO2 essentially mean the same thing. Sure, there's a technical difference, but. This patient is going to present with non-specific dyspnea. We talked about that. This patient's going to be breathing quicker because they have a low PaO2. They're hypoxic. Okay. Tachycardia. They're hypoxic. Tachypnea. Okay. They're breathing deeper. They're hypoxic. That's what you expect this person to show up with. Accessory muscle use. This is an important sign. Why is accessory muscle use an important sign? What's that tell you about the patient's work of breathing?
They're working hard.
That their work of breathing is beyond the capability of their primary respiratory muscles, right? Okay. So, someone who's using accessory muscle use might very well be in respiratory distress, impending respiratory failure, okay? Nasal flaring, especially in kids. Has anyone had a chance to see nasal flaring? Adults do it too, okay? Every time the patient inhales, their nares literally get bigger, okay? The body is trying to reduce airway resistance and pull in more air, okay? Pedal edema. Well, what the heck does pedal edema have to do with breathing? Swelling in your feet, okay? Well, that means that we've got an issue with blood circulation, don't we? Okay? We've got gravity pulling blood down to your legs, where normally it should be able to circulate back up. Okay? So we have some cardiac dysfunction. Cyanosis, okay? Peripheral or central, okay? What's that telling us?
Hypoxia.
Tissues heavy.
We're not perfusing, oxygenating tissues. Confusion to coma if there's central nervous system dysfunction, okay? And organ failure, altered level of consciousness. Brain, kidneys, and the rest from there. This is what your patient's gonna look like. They're gonna look bad, okay? They're gonna look like a hypoxic person. What are these people gonna sound like? Okay. If they're wheezing, here's some of the signs, or here's some of the potential causes. Bronchospasm, okay? That's the most common cause of wheezing, is airway constriction. Okay? Anytime you hear wheezing, you're thinking airways. Yes?
So what is the expiratory wheeze after a treatment? That's pretty common.
That means you actually open them up enough to wheeze.
Oh, okay. So they'd be wheezing.
That's a positive benefit. That's a good thing to hear.
Okay.
If it went from diminished to expiratory wheeze, that means you opened up airways where they can actually move air. Okay, it could be fluids or upper airway disease. It'd be upper airway constriction or swelling. Now, wheezing we can do something about. What do we do about wheezing? We give bronchodilator. Okay, so we take a listen to the patient and they're diminished bilaterally. Okay, super common finding with emphysema. Okay? All the parenchyma of the lung is like bubbly now. It's not this. So when you think of the parenchyma of the lung, the tissue of the lung, think of a sponge. Okay, There's little airways in there, okay? When you put it under the sink and get it nice and wet, it's just like a wet lung, okay? Now, could you take a little needle and stick it in a sponge and drain the water out of it? No, okay? It's the same thing when people have fluid issues in their lungs. It has to be taken care of medically. You can't do it mechanically, okay? So, diminished bilateral breath sounds common with emphysema. Does emphysema cause a VQ mismatch?
Yes.
Yeah. Increased dead space, okay? You're gonna have a high VQ mismatch. Yeah. Unilateral abnormalities. What's unilateral mean?
Just one lung.
Oh,
Opposite.
one side.
One side, okay? Unilateral is always one side, okay? Okay, so that means there's something going on with one lung that's not going on with the other lung, okay? So, wheezing, one lung could have a lesion in the airway, okay? When someone goes into bronchospasm or has an asthma attack, it's never a unilateral thing, okay? Both lungs will constrict their airways, okay? It's never just one. One might be more significantly constricted than the other, but they're both gonna constrict, okay? Absence of breath sounds in one lung. Should that get your attention? Should that have you pulling the patient's x-ray? Absolutely, okay? You could have a pneumothorax, you could have a big old pleural effusion in there, okay? Could be a number of things, okay? Patient could have had the lung surgically removed, right? They go, whoever has a lung surgically removed, yeah, go work in the hospital for a few years. You're gonna meet a few people, okay? And it's funny, because often you can hear breath sounds on both sides. Yeah, I've seen some, I looked at an x-ray of a guy who had a total, I think it was a right-sided pneumonectomy, and his left lung had expanded so much, it looked like just one giant, almost like square lung, and it was so weird. And then I've seen other ones where the lung's totally missing, but that cavity is filled full of pleural fluid. And does fluid transmit sound? Absolutely. Okay. You ever stick your head in the swimming pool and you can't tell what they're saying, but you can hear people talking in the water, like way down at the other side? Okay. Water transmits sound very well. Unilateral crackles. Okay. Crackles on one side or the other. Some kind of infiltrate. Okay. Alveolar filling process. Just a silly way to say unilateral infiltrate of some kind, okay? A right upper lobe pneumonia. You're gonna hear crackles on the right upper lobe. You won't hear them on the left, okay? Because the pneumonia is not present on the left. All right, so that's just, VQ mismatch is such a broad term. They go, here's what someone with VQ mismatch might sound like. And then they give you the breath sounds for like all the different lung diseases. Okay, we're gonna talk x-ray for a little bit, okay? So radiographically, a VQ mismatch can present as black or white. Well, guess what? There's only two colors on an x-ray, black or white. So again, we're being extremely general, okay? X-rays are shades of gray, okay? So, if you have a chest x-ray, which is what a radiograph is, okay, that's another term for x-ray, that is black, okay, is dark, has very dark lung fields, okay, that means there's a bunch of air. Okay? Hyperinflated lungs, extra air. Okay? White, okay, evidence of partial or total alveolar filling, okay, there's an infiltrate in the lung that has partially or completely filled the lung. And sometimes you'll see entire lung whiteouts. Restrictive lung diseases will often have a much lighter radiographic image because in many restrictive lung diseases, the tissue of the lung is thicker, okay? So the more x-ray that goes through the patient and hits the radiograph panel behind them, the darker the image will be, okay? So if there's more air in the chest, you're gonna have a darker image. If there's less air or more lung tissue, you're gonna have a lighter image. That's why bones are white on an x-ray, okay? They don't let the radiation through. Okay. So your x-ray can look like anything. Oh, cool, here's shunts. All right. Evan? There's your anatomic shunt, buddy. Okay. Okay, so extreme version of a VQ mismatch in which there is no ventilation to match perfusion. Okay? This is taking things pretty far. Okay? It's just ventilation. Perfusion is greater than ventilation, which is what this is saying. Okay. So the reason that your textbook normal VQ ratio is 0.8 is, remember these two guys? Thesbesian and bronchial drainage from 117 when you all were having strokes.
What is this Bayesian? What is that? I don't remember the top one.
Me either.
Oh, okay. I might have pulled it out specifically just to like not drive you guys insane. It's simply, it's another, it's blood flow being provided like to your heart itself.
Oh, that makes sense.
Okay,
Yeah.
feeding the heart tissue itself, where bronchial circulation was feeding all the tissues of the airways, okay, feeding the plumbing of your lungs. Okay. So these two things, they get the oxygen in them consumed, and then they dump into the left side of the heart, which gets pumped out to the body. So it adds a little bit of deoxygenated blood. Okay. Does that matter when we're calculating VQ mismatch?
Yeah.
If it's above 1, it's a high VQ mismatch. If it's below 1, it's low VQ mismatch. Okay. Yes.
Does that mean the lungs and the heart get the most oxygenated blood?
Your heart's the very first thing that gets oxygen.
Probably a good thing.
Yeah, your heart likes oxygen. When it doesn't get oxygen, you're having a heart attack.
Ah.
Okay. Now that's a normal anatomic shunt. So your body is designed to operate just fine with this 2 to 3% venous admixture is another term you might hear thrown around. Because essentially it's venous blood at this point being put into your arterial system. Okay. So pathological anatomic shunts as opposed to normal. You see the term pathological, what's that mean? Disease. There's a disease there. Okay. There's abnormal, it's bad. Okay. Results in blood flow from right to left heart, okay? Atrial or ventricular septal defects, okay? Literally, there's a hole in the septum of the heart that separates the right and left, okay? So that would be like your patent ductus arteriosus, okay, PDA. Or pulmonary arteriovenous malformation. I don't know if you guys have heard this before. Yeah.
Do all babies that start out with a hole in their heart and then okay? Okay.
Yep. It's there for when you're in utero,
Okay.
inside your mother.
Okay, gotcha.
And then as soon as the pressure gradients change, as you breathe oxygen and your lungs inflate, that pressure change, the pressure on the left side of your heart becomes greater and it slaps it shut.
Oh, okay.
Okay, so arteriovenous malformations, okay? This is where artery, capillary bed, and then veins, okay? This is where that capillary bed connection doesn't form properly, okay? This is a very common cause for brain bleeds, okay? Someone's born, they call them AVMs, with an arteriovenous malformation in their brain, where there's a ton of little tiny blood vessels, okay? Years of just living, okay? Obviously exacerbated by cigarette smoking, alcoholism, and high blood pressure, okay? One day, that malformation ruptures. Okay? Blood dumps from the vessel into your brain, you end up with a brain bleed, which can be really bad. Okay? Or you hit your head, okay? That'll rupture an AVM too. That's why you hear those stories of 2 guys getting in a fight, and one guy gets socked and dies. It's often an AVM being torn open. Over one stupid bar fight, right? You accidentally kill a guy, so you're going to prison, they're dead. Yeah. Okay, pulmonary physiologic shunt, okay? Occurs when no ventilation to match perfusion. So, perfusion greater than ventilation, right? This is always gonna be pathologic. There's not normal for perfusion to be greater than ventilation. This should be matched. Leads to hypoxemia as alveoli collapse or fill with fluid or exudate. Okay? So fill with fluid, that would be like pulmonary edema. Exudate would be like a pneumonia. Okay? Alveolar collapse, what would that be? Alexis. Yeah. Oh, look, it's right there. Alexis, pulmonary edema, and pneumonia. Okay. Shunt presents very similar to VQ mismatch. Because it is a VQ mismatch. Okay. And then we just go through all the same things. Guess what? All the signs of this are going to be exactly the same as VQ mismatch. Okay. So according to Kettering National Seminars, okay, which is a company that does like a board exam review seminar thing, okay, that your VQ mismatch has turned into a shunt, okay, when your AA gradient is 300 or greater. Okay. So here we are on our VQ mismatch scale, okay? Over on this side, we're shunting. Once we have an official shunt, okay, your AA gradient will be greater than 300. So who remembers our AA gradient?
That's like 10 times what your regular gradient should be.
It's bad. It's not good.
But I'm critical.
Critical.
That's exactly right. You now have an official shunt, okay? Houston, we got a problem. Okay. Now, how would we determine our AA gradient?
Alveolar minus arterial.
Alveolar air equation. Yeah. You guys get why I made you memorize the alveolar air equation now? Okay. Wasn't because I don't like you. It's because it's important. Okay. So, first of all, we would calculate our partial pressure of alveolar O2, right? Using the alveolar air equation. Now, on room air, what is our PaO2, alveolar air?
159.8.
That's in the atmosphere. What about in your lung?
100.
100. Okay. Our normal arterial P little AO2 is what?
80.
80 to 100.
80 to 100. So what's our normal AA gradient? In the lung, the PaO2 is 100. In the blood, just on the other side of the lung, is 80 to 100. So our normal AA gradient would be
5 to 20.
Less than 20.
0 and 20. Okay? You don't ever really see 0 because no one's AC membrane is just like that, flipping perfect, right? Okay, I mean, like, there is an AC membrane. So what, like 5 to 20? Anywhere in there is cool. Okay? Now, from 20 to 300, okay, is abnormal. Okay? And obviously, someone who has an AA gradient of 50 is going to be living a happier life than someone with an AA gradient of 299, right? Yes.
You can't even have an AA gradient of 300 on room air. Can
On
you?
room air, probably not.
No.
Yeah.
Yeah.
So this is best measured when the patient is breathing 100% oxygen. Okay? That's when you're going to get the most accurate AA gradient picture. I forgot what I was saying. Okay, that was good though. You guys remembered AA gradient and what it was, what it means. Okay. Now, what did I tell you guys to like think of when you pictured the concept of the AC membrane? What's going on there? Like, what is this concept of the AC membrane? Yeah, the relationship between the alveoli, the ability of the alveoli to diffuse oxygen in CO2, okay, and the capillary beds carrying the blood through it, okay? So the AC membrane simply refers to the ability to move gases from your lungs into your blood and back out, okay? And I know I'm kind of beating a dead horse in this, all right? I know it, but I had a student, gosh, I don't even, was she a second year? I don't remember. But we were like way into the program. And she's like, oh, that's what the AC membrane is. I'm like, oh no, I failed you. Okay, so I'm gonna beat the heck out of that dead horse just to make sure. Yes.
Physically, it's the alveolar wall, the interstitial space, and the wall of the
Just a
capillary.
little bit of fluid and then the wall of the capillary.
Yeah.
Right.
That's what it's like there.
Okay, now I also told you guys to always think of the lung as two separate parts, okay? What were those parts? Airways and the parenchyma. Remember, the airways are dead space. Air moves through them, you gotta have them, but they're just lung. Okay? The parenchyma is where the gas exchange takes place. And where the AC membrane is located. All right. Okay, so a shunt is an extreme version of VQ mismatch in which there's more perfusion than ventilation. Okay? And it's more common. Look, over here on the shunt side, we got a bunch of diseases. Okay, over here on the dead space side, we got, I don't know, what, 4 things listed up there. Okay. Obviously, there's probably more than that out there, but that's the big stuff. Okay. All right, some stuff that you might come across in your patient that's shunting. Okay. First of all, we know they're shunting because they have an AA gradient of
Greater than 300.
greater than 300. Okay. So you could hear bilateral or unilateral crackles. Okay. What would the first thing that comes to your mind be if you heard a patient with unilateral crackles?
One lung.
One lung. There's something going on in that one lung. What are our differentials? What are things that can go wrong with your lungs that only affect one lung?
Pneumonia.
Pneumonia. First thing that comes into my head. Okay, especially if it's up here, up in an upper lobe. Okay. What else can cause unilateral crackles? Atelectasis. Perfect. Good job. Okay, I hear bilateral crackles. What are my differentials here? What could be going on? Something that affects both lungs.
Fluid in the airways.
The fluids, okay? Remember, fluids get into your lungs because of issues with the heart. That's gonna equally affect both lungs, okay? I'm also gonna hear bilateral crackles with systemic inflammatory issues, okay? Someone with viral pneumonia always affects both lungs, okay? Our COVID patients, always both lungs.
Viral.
Viral. Because it's a systemic inflammatory reaction that's causing the issue in the lungs, okay? The issue is flowing through their blood. It's gonna reach both lungs, okay? So your COVID patient is always gonna have bilateral plug infiltrates, okay? Because they're in acute respiratory distress syndrome, which you'll learn a lot about later on, okay? ARDS, yep. Okay, so bilateral or unilateral crackles, you might hear them both. They mean very different things. Okay, again, this is about as general as it gets. Unilateral absence of breath sounds, okay? What might cause unilateral absence of breath sounds?
Pneumothorax.
A pneumothorax. Okay, what else? A lobectomy. Did you say atelectasis?
Yeah.
Absolutely, significant atelectasis, collapse down a whole lobe, sure. Okay, mucus plug, no fresh ventilation going into that side of the lung, all the oxygen diffuses into the blood, that lung just turns into a little prune in there, okay, collapses in on itself. Okay, so, unilateral absence of breath sounds may indicate significant collapse, okay? Pneumothorax could be included in that. A mass, okay, again, a mass in the airway, a cancerous mass or even a benign mass in the airway does the same thing as a mucus plug. It causes the lung on the distal end to collapse on itself. Okay. Or pleural effusion, instead of it being, the issue being in the lung, it's in the pleural space. Okay, that fluid is pushing up and collapsing the lung tissue. All right. The parenchyma on the chest radiograph may be white. Okay, next. It's so broad, you guys. Perfusion is greater than ventilation. You're more likely to have a white, predominantly white chest x-ray because the lung tissue is denser. It's either collapsed in on itself, and now it's denser, okay? Or the disease process itself causes thickening of the lung tissue, which will cause it to be lighter, or there's some kind of infiltrate in the lung, which again makes it denser, makes the tissue thicker. Okay. All right, now anatomic shunts may be harder to diagnose because the chest radiograph will generally appears normal. Okay, so remember, anatomic shunts, pathologic anatomical shunts aren't affecting the parenchyma of the lung. They're generally cardiac. Okay. Can be diagnosed by using 100% O2 breathing techniques, contrast enhanced echocardiography. Okay, anyway, you don't need to know that. Okay? You don't need to know that. If they suspect it, a pathologic anatomical shunt, they're going to call up our friends down in the ultrasound department, which I think is just right below us, down on first floor here. They're going to do an echo and they're going to look at your heart, and they're going to be able to see the flow. They're going to use their Doppler imager, and they're going to see the flow going the wrong way. They're just going to look at it. Okay, so that was shunt. We're going to stop talking about shunt here for a little bit, okay? And we're going to start talking about diffusion impairment. Now, do they consider diffusion impairment part of a shunt? No. Guess so. Okay, so when we think of diffusion impairment, first of all, we think of diffusion in lungs. What are we thinking? Remember, it's different than perfusion, it's diffusion.
That's the gas exchange.
The ability of gas to cross the AC membrane. Okay, I'm kicking that dead horse, I know it. I'm gonna keep going. Okay? We're having an issue getting oxygen across the AC membrane. Okay? Classic signs of diffusion limitation, hypoxemia that occurs with exertion. Okay? I'm just sitting here, I'm okay. As soon as I start moving around and increasing the oxygen demand on my body, I'm gonna get dyspnea. I'm gonna be working harder, okay? I sit down and rest, and I'm able to catch my breath eventually and go back to a steady state. Okay? Now, impairment or diffusion impairment, by definition, is gonna be an increased AA gradient, right? You should be thinking that right away. Okay? It can be caused by thickened, scarred parenchymal tissue. Okay? And we're almost always gonna think of this as a fibrotic process, fibrosis. Okay? The lung has been injured in a systemic way, not like it got poked with something, but like it got inflamed. And during the healing process of all this lung tissue, collagen was left, okay? Scar tissue, okay? Scar tissue is thick, okay? Same collagen that your body would use to repair a torn ligament is now in your lungs. Does that allow gas to cross? No, it's not what it's for, okay? It's thick tissue that's simply there to repair damage, okay? So you end up with lungs that are fibrosed or have fibrosis, okay? It's gonna make it much more difficult to diffuse gas across the AC membrane. Yes?
It's usually autoimmune or what causes?
Potentially, yeah, so there's actually a lot of causes for it. There's quite a few different fibroses out there. Pulmonary fibrosis, as you can tell by the name, pulmonary fibrosis, that's a pretty generic name, right? It just means fibrosis in the lungs, okay? Is its own thing, okay? Again, there's whole books written about it and all the different kinds, what causes it. Most of the time it's idiopathic, that we don't know what caused it, okay? But we do know that certain medications can cause it, okay? We do know that certain environmental situations can cause it, okay? So common with welders, okay? Common with factory workers that don't have proper respiratory protection. Their lungs get inflamed by these chemicals time and time again, right? Their body's repairing the damage over and over and over, putting that collagen where it shouldn't be. 20 years of that, and guess what? Your lungs are full of collagen. Right? And it's a really terrible way to die. Nothing you can do about it except like high dose steroids and get on the lung transplant list. Then even once you get your new lungs, like your number's up. You only got a few years.
Couldn't like bore through the airways or something, like take the collagen out of there?
The problem is that it's all the way, your alveoli are now lined with
Oh.
collagen. Yeah, it's all the way down to the microscopic level. All right, so if you do anything that involves chemicals or anything like that, wear your freaking protection, okay? Fibrosis is also a big part of what's called the long hauler COVID syndromes, okay? Their lungs were systematically inflamed. We then doused them with huge amounts of oxygen, huge concentrations, which further degraded their lungs. Okay, they survived, their body healed the damage to the lungs, but to heal the damage to the lungs, it used collagen. And now the lungs don't diffuse oxygen anymore. Okay? We did what we had to do to save their lives, but it's going to affect the quality and length of their life. Sucks. Okay, so all these things cause diffusion impairment. Fibrosis, asbestosis, okay, breathing in that asbestos that they were making everything out of back in like the 60s and 70s, right? Causes fibrosis. We just call it asbestosis because that's what caused it, okay? Alveolar destruction, emphysema, okay? Do we remember why smoking causes emphysema? I know I told you guys. Oh, I'm going way too slow.
Destroys the elasticity of the alveoli.
Yep, destroys the elasticity in the alveoli because when you inhale that smoke, remember those macrophages, okay, your lung defense, it envelops that particle and releases its digestive enzymes, okay? Those enzymes also digest part of your lung, okay? So if you're always smoking and you're always putting that material into your lungs and your macrophages for 20, 30 years are always grabbing up these particles of ash and releasing their digestive enzymes, you dissolve away a bunch of your alveoli, okay? And that's emphysema, and that's how it happens, and that's why smoking is a big cause of it, okay? There are some what's the word I'm looking for? Other causes for emphysema too, like some people have deficiency in their alpha-1 antitrypsin levels, and it kind of causes the same effect. But by far and away, it's smoking, okay? And then, of course, pulmonary vascular abnormalities, okay? Diffusion impairment. Hard to diffuse when you don't have enough hemoglobin, right? Hard to diffuse when you have a blood clot in the blood vessels in your lungs, okay? Or high blood pressure. Pulmonary emboli, you guys, you're gonna see it happen quite a bit, okay? It's super dangerous. It's super dangerous. Even when you're going on a long car ride or something, stop every couple hours and just get up and move around. I can't tell you how many people probably die every year just going for a long car ride, getting home, getting in bed, and waking up dead. So most pulmonary emboli are detected during autopsy. Okay, that's how most of them are found. Person's dead. Okay, so clinical presentation of diseases causing diffusion impairment: dry cough, fine bilateral crackles, often more prominent in the bases. Okay, but notice bibasilar, both lungs. A diffusion impairment disease, okay, is pretty much characterized by affecting both lungs. Okay? If just a part of your lung had an impaired, ability to diffuse, the rest of your lungs would kind of make up for it. Okay? It becomes an issue when the majority of both lungs have this issue. Jugular distension and edema. Okay, JVD, jugular venous distension. Okay, sign of right heart failure. and pulmonary hypertension, okay? So there's a lot of work being placed on the right heart. And obviously an increased AA gradient.
So this part would be both of them.
Yep, so you have two jugulars, right? You'll see it kind of bulge under the skin right here. It'll be quite pronounced. That's because blood's backing up instead of moving through the right heart.
Is that only gonna be pronounced on the left side?
No, I think so. I could be wrong. Okay, so we talked about VQ mismatch being a cause of hypoxemia, with shunt being an extreme form of VQ mismatch, okay? Now, VQ mismatch as it is, has a shunt side, okay? Which is perfusion greater than ventilation, and it has a dead space side, okay? But when the patient is actually shunting, okay, is when we have an extreme form of this side taking place, okay? What else did we talk about? We just talked about diffusion impairment. Okay. So technically, I guess we'll say 1, 2, 3. Okay, so with diffusion impairment, okay, you can have adequate blood flow, you can have adequate ventilation, but the oxygen is not crossing the AC membrane, and that's what separates it from a VQ mismatch. Okay. All right, now we have decreased inspired oxygen. You're not breathing in enough oxygen. Okay. Decreased O2. Why'd I put Q2? Drug orders here. Decreased oxygen environment. Okay. Which I like to call hypoxemic hypoxia. All right, high altitudes, mountain climbing. There's a really cool video on YouTube. I could probably find it if I looked for it. But a guy, he's on K2 or Everest. I don't remember which one. And he doesn't have his oxygen on. He has a pulse oximeter on his finger. It's reading like 78%. Yeah, it's like, this guy's nuts. And those, the Sherpa, the people that like live in the high Himalayas, they have a genetic mutation that makes them polycythemic. They have tons of red blood cells. And they think it's like an adaptive thing for living at high elevation for hundreds and hundreds of generations. All right, so you're gonna see this at high altitudes. There's simply a low partial pressure of oxygen at altitude. Yes?
People in the Andes Mountains in I think it's South America, they have a genetic mutation that messes with 2,3-DPG, I think.
Oh, okay.
Yeah, it's different, but it does the same.
But does the same thing.
Yeah.
Okay, that's a really cool example of like differing evolution or geographic evolution. You know, that's cool. Very cool. Okay, so airlines pressurize the cabins of their aircraft, but they don't do it to 1 atmosphere. Remember that 1 atmosphere is the pressure of all the gases in the atmosphere on your body at sea level, okay? Which can make people traveling that have pulmonary disease more susceptible to having pulmonary issues while on the flight, okay? Has anyone ever been on the flight and the stewardess hustles over and grabs the O2 tank and brings it up to someone? I've seen it once, okay? That's what's going on, okay? So as soon as you're in an environment where the atmospheres are different, okay? People with like pulmonary hypertension, it can cause a lot of trouble with them because all the blood vessels in their lungs start to constrict. Okay? So what you do is you just give them oxygen, that'll redilate all those blood vessels and they'll feel better. Okay. Now, I think they don't pressurize all the way to 1 atmosphere to prevent accidental like fires. Okay? Is less likely to cause a fire on an airplane, even though everything is fireproof. You know people these days, right? There's a reason the stewardess has to go, it is a federal crime to smoke cigarettes in the laboratory or tamper with the smoke detector. The only reason they say that is because someone's tried it, right? Signs and symptoms of hypoxemia may present, treat it with oxygen. Patient is in a low oxygen environment, give them some oxygen. Be nice, jeez.
I remember seeing lots of people having issues when they go to like Lake Tahoe, when you're
Mhm.
10,000 feet in the air,
Yep,
and
Yep.
they've been at like sea level, they'd always come in with breathing problems.
yep, that's exactly right.
There's a place we could run into that around here is confined spaces. Like if there's been a nitrogen purge on a tank or something, somebody stuck their head in for too long or was inside the tank or something.
All right.
Like, we could see that.
That makes a lot of sense, yeah, industry, right? Because you would purge it with nitrogen specifically to push out all the air, right?
Especially if
Make it
it's,
inert.
if the chemical is flammable, they use nitrogen for tanks.
Can't have a fire without oxygen. Yeah, absolutely. Okay, yeah, thank you, that's a great example. Venous admixture, I mentioned this earlier, okay? This comes from shunts. Decreased mixed venous oxygen, okay? Clinically, patient's lung must add more oxygen to blood, okay? Presence of pulmonary disease may prevent this from happening. So, you have someone who has adequate blood flow, okay? But they have a dead space issue, okay? So the blood's flowing by the lung, and remember, it's coming from the right heart. It's still venous blood. It hasn't been oxygenated yet. Okay? If that deoxygenated blood flows through the lungs and the lungs are unable to oxygenate it, well, guess what? It's gonna get pumped out to your body with a low oxygen, okay? And this is what we're calling venous admixture. It's the same thing that your Thesbesian and bronchial drainage do, okay? But the point is, just like everything else we're talking about, seeing how we're talking about hypoxemia, right? It results in a decreased arterial oxygen content. You have low oxygen blood flow through the lungs, goes out to the body, still low oxygen. Okay? So it's essentially venous blood. Okay, now next semester when you get into hemodynamics, you're gonna be looking a lot at this right here. Decreased cardiac output and how it affects oxygen consumption in the body, okay? So if your body or if your heart has decreased cardiac output, it takes longer for the blood to circulate around and reach the lungs again, okay? It's just not being pushed as hard. While that blood is spending more time out in the body, it is getting, the tissues have more time to extract oxygen from it. Okay? So if you look at venous PO2, okay, and it's higher or lower than it should be, okay? The oxygen in your venous blood is lower than it should be. That can reflect decreased cardiac output because your body had more time to take oxygen from it. Okay? And so you'll be able, after next semester, to look at oxygen content of blood going out to the body, oxygen content coming back in, and calculate the volume percents of oxygen that was consumed. Okay? And then based off of that, you'll know if you have decreased or increased cardiac output. It's not as scary as it sounds. All right. Signs and symptoms of congestive heart failure and or underlying pulmonary disease are often seen with this increased venous admixture, which is a result of often decreased cardiac output. Yes?
So it's decreased O2 in the venous and the arterial blood?
It results in decreased arterial.
Okay.
Yep. Because if you're, okay, so if you're taking blood that's lower in oxygen than it should be,
Yeah.
and running it through the lungs, it won't necessarily have the time to get all the oxygen that it needed because it started at a low point. So, yeah,
Won't the increased gradient make up for it a little bit, or
maybe a little bit.
not enough?
Yeah.
No.
The end result is decreased arterial O2 content.
Okay.
All right. 1, 2, 3, 4, 5 is essentially decreased cardiac output. We'll call it venous admixture. Alright, guys. There's the 5 things that cause hypoxemia. That's what it is, right there. Did you know the 5 things that cause hypoxemia as a respiratory therapist? Yep. Absolutely. And in a way, it simplifies things, doesn't it? You have a hypoxic patient. Guess what? There's only 5 things that can cause it. Okay. And I'm not going to say we just learned them, but we briefly touched on each one, so we have an idea, right? Yes.
Would 5 be a VQ mismatch?
Would this be a VQ mismatch?
Yeah.
Man, I'm so inclined to say yes, but we're going to think of it as separate things. Okay. That's why VQ mismatch is the most common cause. Like, there's flavor of VQ mismatch in all these bad boys except for decreased oxygen environment. But even then, you're like, well, that could be decreased ventilation. Okay, so any hypoxemic patient you come across, one of these 5 things, or a combination potentially thereof, can be the reason they're hypoxic. Only 5 things. Okay. You come across someone who's short of breath. Okay. They're sitting on the edge of their bed in the tripod position. They got nice swollen, shiny ankles, skin's pulled tight. You listen to their back, bilateral crackles. Okay. Decreased cardiac output. That's why they're short of breath. Heart failure. Yeah.
Crackles are effusions, right?
In this case, in the example I'm thinking of, it's gonna be pulmonary edema.
Pulmonary
Yep.
edema. What's the difference between a bilateral effusion and a pulmonary edema?
So, okay, that's a good question. The effusion is in the pleural space, pushing the lungs up, okay? The pulmonary edema is water and some blood from the blood vessels in the lungs spilling through into the alveoli because of pressure changes.
That's why it's important to put them on BiPAP, get the pressure, push everything back into.
Yep. So, you'll hear cardiogenic crackles. So crackles caused essentially by the heart, pulmonary edema, okay, referred to as rales or rails. Okay. They're actually trying to move away from the word rails and just use fine crackles for everything. But if you want to call them rails, go for it. And I heard a term, my buddy Joe Lindsay, rolling rails. Okay. We walked up in exactly that scenario, okay? Guy's in the tripod position, ankles size of his knees, you know, and just totally swelled up. You can hear this guy just crackling from the doorway. Oh, rolling rails. And that guy went on to buy that. Okay. So, differentiating between causes of hypoxemic respiratory failure. Focus on 3 main causes. Hypoventilation, okay? Here's a normal AA gradient. I'm not sure why they put that with hypoventilation, okay? VQ mismatch, that seems like where that should be. And then shunt. Little or no improvement even on 100% O2. So remember we talked about a shunt. Your AA gradient is greater than 300. It's best to measure that on 100% O2. Okay. Yes?
If your AA gradient is 200, that's still not good.
It's still not good.
Like
yeah.
what? So shunt, that's just the definition of a shunt.
Correct.
Okay.
Yeah. They had to define it at some point, so that's what they decided to use as 300. I'm sure they had a reason. I don't know what it is. So with a shunt, since you can't improve the oxygen, the arterial oxygen content, just by supplying oxygen, you're gonna add pressure. And that's how you're gonna fix it. Okay. All right, that was type 1 failure. We got 3 more. No, this is the longest one, okay? So, 5 causes of hypoxemia. It's super important that you know these as a respiratory therapist, okay, guys? And just memorizing them now, taking the time to understand them, is going to make your job so much easier. It really will. There's plenty of RTs out there that show up to a rapid response or a call from a nurse or whatever, and they can see the patient's in distress. You know, they can give them a breathing treatment or get a BiPAP or something. But fundamentally understanding why the patient is in distress escapes a lot of people. It's not just RT, it's everyone, okay? So understanding that there's only 5 reasons someone's gonna be hypoxic, okay, is huge. It really helps simplify things in your mind when you go to look at a patient. Okay, so let's talk about type 2 failure. This is hypercapnic or ventilatory failure. And we've kind of already talked about this stuff quite a bit, haven't we? Okay, here's our definition. 725 and falling, CO2 50 and rising. You've heard that before, right? Dead horse. Okay. Okay, elevated PaCO2 results in uncompensated respiratory acidosis. You guys told me that earlier. Awesome. Okay. AKA pump failure, okay. Like, that's stupid. It just makes me think of hurt, right? Okay. You guys remember back in 117 when we talked about the way ribs move? The pump handle and the bucket handle? Okay, that's what they're getting at here. Or I guess bucket handle will be this way and pump handle will be this way. Okay. Let's just stick with ventilatory failure, okay? Because if you walk into a patient's room and they have an uncompensated respiratory acidosis, oh, they're in pump failure. No one's got a flipping clue what you're talking about, okay? Yeah, yeah. What are you talking about? He's not CHF. He's hypertensive. How can you say he has pump failure? Oh, no one knows what you're talking about. Okay, ventilatory failure. Alveolar hypoventilation, okay? A state of decreased or inadequate ventilation. Absolutely, hypoventilation, okay? Leads to an increase in PaCO2, which we call, come on, don't fall asleep, China. I should go yawning. You can call it hypercapnia. You can call it hypercarbia. You can say they're hypercapnic, okay? All means the same thing. You ever read the ingredients on that bad boy? Hey, I like them too. I don't care. I just know.
What?
So mechanically separated.
Oh my God,
means-
China.
Do you know what that means?
What?
Mechanically separate meat.
God, everything.
Enlighten
It
us.
means they take all the scraps
And
they
put
put them
them
in a
in
cylinder and crush it all down, and the ooze that comes out the other side is mechanically separated.
Bye.
And then beef hearts. They grind up beef hearts.
Delicious.
And we like.
Oh, there's some pork in there too. I don't know. You can call pork snouts pork, so they're good though.
They are.
You just can't think about it.
No.
Nope.
Giving my kids and everything. I don't care. Okay, so anytime you have an increased arterial CO2 content, you're in a state of hypercarbia, or the patient would be considered hypercapnic. Okay, and this is always associated with ventilatory failure. With chronically elevated CO2, the ventilatory response to a further increase in PaCO2 is more blunted. So what's that mean? Okay. That means our chronic lungers, our CO2 retainers, our fully compensated respiratory acidosis patients, okay? They are at a higher risk of going into ventilatory failure, okay? Their CO2 has been elevated so long that the chemoreceptors in their brain are dulled to the CO2, okay? So if the CO2 increases a little bit more, they don't have the same drive that you and I have to breathe faster, okay? So they can't get rid of it very easily, okay? So that they're at a much higher risk of that CO2 jumping up quickly. Okay? Now, where are we keeping these people's oxygen?
88 to 90.
88 to 92. Yes, Jen.
So I had a patient that it was in her chart that she needed to be between 88 and 92.
Bam!
But she wore 4 liters at home and she was on 100. She was at
You're gonna
100%.
see it all the time.
Okay.
Did you try turning your oxygen down?
I asked her if I could.
What'd she say?
No.
Yep.
I said, "Can you try?" She said, "No." Okay.
Flat out.
Goodbye.
Yep, you're gonna see it all the time, okay? People become highly attached and kind of develop this like dependence, okay? Where they know something's wrong, it causes them anxiety, okay? Their doctor told them that they're gonna wear 4 liters at home. They got tested for 4 liters at home, and who the heck are you to come and turn it down? Okay, okay, I get it, okay? Is it the best thing? No, okay? A lot of these people, you know, if you ain't first, you last. I want to be 100%, right? Because 100% is good. They just don't understand, okay? Or they've developed a psychological dependence on seeing that little number. Okay? Have you guys run into people that have their own pulse ox? They're usually on Homo 2, and they're obsessive about it. And yeah, and even if you do titrate their oxygen, next time you see them, they're gonna call you out. I told you not to turn it down. Because guess what? As soon as you left the room, the first person to walk in, guess what they did? What's my O2 at? I knew he turned it down. I knew it. Okay. What are you gonna do? You know? I'm sorry. I apologize. I understand you want that left where it was. Here's my orders. Okay. All right, and then throw it in the chart. When you're charting your treatment, okay? Patient refuses O2 titration. Current oxygen saturation, 100%, whatever. Okay. So, your chronic lungers, okay? Their CO2 is chronically elevated, okay? Their kidneys have compensated for it, so they have a normal pH, but they're at a much higher risk of going into that ventilatory failure and not being able to compensate for it. And we can help avoid that by keeping their oxygen levels low, because that'll force that ventilatory trigger that they're running on. Okay. All right, so this is kind of like random, okay? Egan's has it in here. So I was like, okay, maybe they want you to know this, okay? I should look in Kettering and see if they mention it in Kettering. I don't think they do. Unexpected exposure to breathing carbon dioxide. This is a pretty like niche thing. It doesn't, you aren't gonna see this very often, okay? Or in the United States we say niche. It's a niche thing, right? It's pronounced niche, just FYI. Okay, there's an accent. Although most cases of increased PaCO2 are due to hypoventilation, and unexpected exposure to CO2 can occur in certain situations. Okay. Clinical presentation. Follow unusual clinical scenarios. Okay, clinical presentation follows unusual clinical scenarios. Okay, they even say it's unusual. Yeah. Defective CO2 scrubbers in the setting of anesthesia machines or life support systems in scuba units. This can happen, okay? Scuba is wearing rebreathing apparatus, okay? The CO2 scrubber that's within their enclosed system is just soda lime, okay? Once it's saturated with carbon dioxide, it no longer absorbs carbon dioxide. So you sit there and rebreathe your CO2. There's actually a really cool video, again, I'd have to dig it up, of this happening to a diver, okay? There's a couple of guys, they do like, cave divers react. And like, they'll watch a video, like usually it's something going wrong, right? And they'll react. Anyway, it's pretty interesting. So this video, it shows this guy using this rebreathing unit, and they're diving, they're not that deep, they're maybe like 40 foot of water. And they're diving like an old, it's like a, I don't know, a fishing dinghy that had sunk or something, they're just kind of around it. And he's just swimming around being normal. And then you notice that in between breaths, you know, you get some bubbles when the patient or when the person exhales a little bit. Next thing you know, there's just nothing but bubbles coming out, okay? Because guess what the guy's doing? He doesn't know it. He's hyperventilating. he can't stop it, okay? Because he's rebreathing his own CO2. Luckily, the two guys with him realized what was happening, because about 30 seconds after he started breathing like that, he became unresponsive. And they were able to swim over, and the guy lived, but could very well have not, okay? So if you're gonna get into scuba diving, and if you're gonna get into scuba diving with non-rebreathing tanks, I'm scuba certified. Anyone else scuba dive?
Hell
Oh,
no.
that's awesome.
I don't like any, I'm scared
Then
of
you need to be
water.
changing out your soda line between dives. Okay, just that simple. Anesthesia machines use the exact same soda line to scrub CO2 from their circuit. Remember, they're anesthesia machines. They have anesthesia gas moving through them. They can't just vent it into the room like our ventilators can, or everyone in the operating room is gonna pass out, right? So they have to recycle, constantly recycle all the gas moving through their circuit and put it back into the patient. And the way they get rid of the CO2 is they run all that gas through the CO2 scrubbers. Okay? And actually, the new soda lime stuff, it changes color when it wears out. It goes from white to blue. When your soda lime turns blue, you swap it out. Okay. So this can happen in airtight chambers. I guess in some industrial applications, you could have something like this happen. Okay, someone goes into a cylinder, sticks their head in a cylinder that's full of CO2 instead of oxygen. Spacecraft? Anyone gonna be an astronaut? Okay, well, if you ever do, like, hit me up, take me on a tour, okay? And remember, CO2 kills. Okay, and submersible crafts, okay? These are gonna be your submariners, your explorers, okay? People going down to look at the Titanic, stuff like that, okay? Sorry, that was a bad joke. Occupational exposures, spelunkers in caves. People like to explore caves. And I think people that explore caves are insane. Individuals who work with dry ice. You know that's what dry ice is? It's CO2 gas. It's, yeah, frozen. Miners and firefighters. All these people are at higher risk of being exposed to high doses of CO2. Okay. As opposed to going into an environment that's high in CO2, what causes increased carbon dioxide production within our body? Okay. A few things I think we already know. Okay. Fever. When your temperature goes up, your CO2 production goes up. When your temperature goes up, your cells eat oxygen at an increased rate. Okay? Just like burning gasoline in your car. The more oxygen you consume, the more gasoline you burn, the more byproduct you produce. Agitation. Okay? Okay. When you're agitated, you use more oxygen. Exertion. Okay? You're doing something difficult. You're working out. You're doing, I don't know, something that causes you to exert. Okay? You're going to consume more oxygen. Okay? I don't even want to know. All right. Shivering to try to warm your body. Okay? Is going to consume more oxygen because what's all that muscle tissue doing? It's causing you to shiver. It's contracting and releasing, contracting and releasing, contracting and releasing. Burning oxygen. Hypermetabolism. I don't know. You got a hyperactive metabolism. Hey.
Isn't all of this kind of like hypermetabolism? It's all stimulating more ATP to be produced.
I completely agree with you. Yeah. It's all essentially increased metabolism rate. Yep.
Someone with Graves' disease.
With what?
Graves' disease.
Something all cold. Yeah.
They shiver a lot.
Oh, yeah, probably. Yeah. Okay, and then excess caloric intake, especially carbohydrates. Okay. Increased carbohydrate consumption leads to increased CO2 production. Okay, remember that respiratory quotient, 0.8? You can change that from 0.8 to other things by eating a bunch of carbohydrates. So our COPDers, do we encourage them to eat a high carbohydrate diet? Nope. Small, high protein, high fat diets. Sounds good to me. A steak, baby. I was gonna make a joke about hypermetabolism being me until my 40th birthday. I got my Miller Lite, baby girl. All right, clinical presentation. Mechanically ventilated patients with an already compromised lung function, they're gonna have increased carbon dioxide production, I guess. Alright, impairment in respiratory control. Impairment in your brain's ability to take breaths. Obviously, right here up the top is the one that pisses me off the most, drug overdose or sedation. Okay. Unfortunately, it's one of the more common things you're gonna see, okay? You override your brain's ability to trigger you to breathe, you're not gonna breathe. There's nothing you can do about it. Okay. Sedation, you're gonna see this a lot in the hospital, okay? Every single one of you is gonna be asked to stand by for a conscious sedation. They're usually hilarious, okay? But yeah, it's gonna knock out the patient's ability to breathe. Do you want a respiratory therapist standing there when you're giving meds to a patient that's likely gonna knock out their ability to breathe? Absolutely. Okay. And when you do go down for a conscious sedation, you always bring an ambu bag, okay? You always bring an oral airway. Take the ambu bag out of the little carrying protective bag that it comes in and hook it up and have it ready to go. Nothing will piss your doctor off more than her giving a bunch of meds to set, I don't know, the kid's ankle or something. That person becoming, or stop breathing, becoming apneic, and you fiddling to get your ambu bag out of the freaking carrying bag that it comes in. Just have it ready, whether you have to use it or not. On the way out, trash. Or if you didn't use it, I don't know, throw it in the back of your car, or give it to me so I can use it in class.
I see a lot of RTs like pre-oxygenate people before that anyway,
Absolutely.
and all they do is set the ambu bag on them and give them oxygen.
Now remember, with our self-inflating bags, you do have to squeeze the bag to deliver oxygen to the patient, okay? But yeah, before a conscious sedation, I'll usually throw a nasal cannula on the patient. Yep. Okay, so drug overdose, far and away the most common cause of decreased ventilatory drive, okay? You're also gonna see this brainstem lesions in diseases of the central nervous system, okay? Multiple sclerosis, Parkinson's disease, all this can affect the person's ability to take a breath, okay? Also, ALS, Lou Gehrig's
Lou Gehrig's.
disease, yep, that's another common one there. Pretty sad. Okay. So hypothyroidism. I guess I don't really know how that affects the respiratory drive. I'm sorry, I don't understand it fully.
Is it like
Okay.
low thyroid?
Yeah, it'd be like low thyroid activity, low thyroid levels. TSH, is that what they measure with? TSH level?
T3, T4, TSH.
Yeah.
There's a bunch of them. Okay, so that can affect your respiratory drive. I don't know if I've encountered that in practice. Maybe I haven't in practice. Okay. I suppose I should look into that a little bit more. Morbid obesity, okay? How does morbid obesity affect ventilation?
Physical restriction.
Restrictive process, okay? You lay down at night to go to bed, okay? Where does that extra weight on your chest and abdomen end up? Okay? More on top of you than it was when you were standing vertically, right? Okay? So you're gonna hypoventilate during the night.
For obese patients?
Yep. That's why it's so common for obese patients to have CPAP. Because it turns into a big deal, you know? I think I talked to you guys about this before. You're getting hypoxic at night. What are the blood vessels in your lungs doing when you become hypoxic? They're vasoconstricting, okay? They're saying, uh-oh, I'm hypoxic, I'm gonna vasoconstrict so that less blood can go through me because there's no point in putting any blood through me, I don't have oxygen for it. The problem is, it's both your lungs, your entire lungs. So they all vasoconstrict and it puts a ton of extra pressure on your right heart. Do this for 20, 30, 40 years, next thing you know, your right heart's blown, man. It's literally like poofed out bigger than it should be. Either that or it's developed Arnold Schwarzenegger muscles, and those muscles have taken up the space that's supposed to be for blood. So it's either hypertrophied or gotten huge. Okay, so sleep apnea, that's a big one, okay? Luckily we can treat that, okay? We've got BiPAP, we've got CPAP, we got ZPAP. I don't even know what that is, but patients are super proud of it. It's a ZPAP, cool. You're gonna wear it? All right, that's all I care about. Okay. Depending on where you work, okay, what the policy is, If someone brings in their own CPAP machine, take a look at it, man. Ugh, God. Okay, check the power cord, make sure that it's intact. I can't even tell you, like, I don't know what happens at these people's homes. I don't know. But,
His dog was chewing on it.
yeah, like, I'm serious, like, yeah, exposed electrical cords. I popped the filter out of one once, there's a flipping cockroach in
Shut
there.
your mouth.
Just hanging out.
Oh.
Just hanging out, dude.
That's just on Thursday, one of the RPs came back to the department talking about this lady's home CPAP. She's like, it was all brown and gunky and it had like bug eggs in it.
I'm
There's no
serious.
filter.
Yeah.
Like,
I took that guy's CPAP and I just dropped it into a trash bag, tied it off, set it in the closet, and went and got him one of ours. Like, you're not wearing this. So, at Orderville Community Hospital, where I worked right after I graduated from RT school, the hospital got sued by a guy for bringing in his own CPAP, which was dirty as hell, and then developing a pneumonia in the hospital. He sued the hospital and won, and then we had to develop all these policies and protocols for checking people's CPAP units because of it. Because it's our fault, right? The understaffed RT department didn't have time to wipe your dirty. The point is, okay, you take a look at these people's equipment. Okay, it's 9 times out of 10 pretty gnarly. And I mean, I get it. Like a lot of these people that have their own CPAPs and stuff, like they have pulmonary disease. Some of them have a hard time even getting up and walking to the kitchen to, you know, like, it is what it is. Okay, so a clinical hallmark of impaired respiratory control is, can you guess? Low respiratory rate. Bradypnea, okay, so lower respiratory rate, lower respiratory volume. Okay. Why does it say beach minute?
I don't know. It's not very
I hope
many.
this isn't one of the slides that I did. I did put my flavor on most of the slides, and that's something I can see myself doing. Okay, so less than 12 breaths a minute, okay? And ultimately, apnea. Okay. Neurologic diseases. We kind of touched on this already, okay? We talked about ALS. What else did we talk about?
Parkinson's.
MS. Yep, Parkinson's. Good, thank you. All right, so neuromuscular disease can absolutely lead to impairment in respiratory and the respiratory drive, okay? So central nervous system signals fail to reach the ventilatory muscles. Okay? Your brain will send an electric signal down the nerve bundles. That signal never reaches the respondent muscle. Therefore, it does not contract. Okay? This can be caused by spinal trauma, okay? That's why a high cervical fracture is super dangerous, okay? This person could not breathe as hard as they try. The signal simply will not travel to the diaphragm and accessory muscles and all that. Internal and external intercostal muscles, all that. It's just not gonna happen, okay? So unless someone shows up with a quickness and breathes for this person, they will die. Okay? Motor neuron disease, there's our ALS and polio, okay? ALS is almost 100% fatal. Polio, you can survive, okay? Often with lasting effects. So, Guillain-Barré syndrome, GBS, it's a motor nerve disorder. Guillain-Barré, it's not Guillain-Barré, it's Guillain-Barré, okay? I've heard RT say Guillain-Barré, you're just kinda like, okay, like, don't say that in front of a doctor, please, okay? What? Ground to brain, right there, Guillain-Barré. Paralysis starts down here, works its way up. Okay? It's not super common, but it's not super uncommon. We aren't exactly sure what causes it, but it has been noted to be more frequent after people receive vaccinations, like flu vaccines, stuff like that. Okay? Most of the time it's temporary. Okay? You put them on a ventilator for a while. What you do is you monitor their ability to ventilate. Okay, you're checking maximal inspiratory pressures, and once they degrade to a certain point, okay, where they can't no longer produce -20 centimeters of water pressure, then you have to intubate them, sedate them, and give them some time, because they'll paralyze all the way up, and then they'll go back down. Yes.
So it's temporary. Okay.
How do you say it again? Browns beret?
Guillain-Barré, Guillan.
With something like Bell's palsy, like that paralyzation.
Yeah, or paralyzes your face. Yeah, I don't think that usually makes it all the way to the respiratory drive
Okay.
center. Yeah. Okay, neuromuscular junction disorders. Myasthenia gravis. Okay. Again, another relatively common issue. Mind to ground. Starts up here, works down. Okay. One of the symptoms, droopy eyelids. Can't hold their eyes open anymore. It'll work its way all the way down. They won't be able to breathe. Temporary. Botulism poisoning. Yeah. We don't deal with botulism too much anymore. Okay, we came up with proper, canning techniques. But the most common, from what I understand, cause of botulism poisoning is like improper preserving of food. Okay, it's not sterilized when it gets canned, and then this bacteria grows in it. You consume it, and it knocks out your ability to breathe. We tried to assassinate Castro with botulism. He was staying in the U.S. doing something, and we're like, we want to kill this guy. So every day, Fidel Castro would go down to the ice cream shop by the hotel that he was staying in, and he'd get a milkshake. So the freaking CIA shows up, 18-year-old kid working the ice cream shop, right? Gives him botulism pills, goes, put this in this guy's milkshake next time he comes in. You imagine you just working at the ice cream shop, CIA shows up, we're gonna smoke this dude. What? What? Whoa. So the kid takes these pills that they gave him, and he puts them in the freezer. Fidel Castro shows up. The kid goes to get them out to put them in his milkshake. They're froze to the freezer, and they just break apart in his hand. Crazy, huh? Isn't that crazy? And muscular diseases. What's MD? Muscular dystrophy?
Yeah.
Okay. And myositis. I guess I'm not sure what that is.
An inflammation of myelin sheath.
Okay, there we go. Myelin sheath covers all your nerves. Gotcha. Yeah, that makes sense. Itis is inflammation. Myelin. Okay, yeah, cool. All right, so neurologic diseases absolutely can affect your ability to breathe. Okay, we've all seen Stephen Hawking, right? Extremely brilliant person in a frail body. Yes.
What did he have?
I'm trying to remember what he had. I think it was one of those. Wasn't it
Is it ALS?
MS, wasn't it?
ALS or MS?
Is he still alive?
No.
He passed
No.
away.
No,
he
no,
passed, but
Okay.
yeah.
Someone Google that, I'm a little curious. Okay. So clinical presentation of neurologic diseases, it's varied depending on what's going on, right? So we already talked about myasthenia gravis, mind to ground, and Guillain-Barré, ground to brain, okay? But drooling, dysarthria, weak cough, ALS, amyotrophic lateral sclerosis. Will someone Google dysarthria for me?
No, I think
Lower
people-
extremity weakness progressing upwards, Guillain-Barré, ground to brain. That's the easiest way to remember it, okay? Ocular muscle weakness, eye muscle weakness. Where are we going with this one? Myasthenia gravis, okay? So ocular muscle weakness, ptosis, diplopia, what? Dysphagia, I know that means you have a hard time talking. Is this one inability to swallow? I'm trying to remember. Dysphagia, inability to talk, that's myasthenia gravis, mind to ground. Different clinical presentations yet commonly result in respiratory muscle fatigue and ventilatory failure. Okay? No matter the cause, whatever causes ventilatory failure is ventilatory failure. Doesn't matter what the cause is. You can have an increased PaCO2, decreased pH, decreased PaO2. Yes?
You wanted me to do Google what? Myasthenia gravis?
Where'd it go?
Miss Arthur.
Weakness in muscles used for speech.
Okay.
Yeah, I thought
What
dysphagia
did they
was
just say?
swallowing.
Yeah,
was
me too.
Oh, is that what it is?
Yeah.
Yeah, I did too, cause
Okay,
like they had to be on
dysphagia.
like a
Dysphagia.
dysphagia diet.
and
Yeah,
dysphagia.
there it is.
Yeah,
Okay, that
dysphagia
makes
diet.
sense.
Dysphagia is swallowing, dysphagia is speaking.
Okay, there we go. There it is. Trouble doing muscle stuff up here.
Right.
Okay.
Diplopia is double vision.
Ah,
Terminology, where are you at?
look at that. These new words. You go home and tell your friends. Okay. So ventilatory failure may occur if imposed workload cannot be overcome. That makes sense, okay? Your work of breathing is greater than what you can do, okay? Most commonly occurs secondary to increased dead space to tidal volume ratio. So, do I really want to get into this right now? Let's do it. We'll do it real quick. Okay. You're gonna have to learn how to do this soon anyway. Okay, so what does this mean? Increased dead space volume to tidal volume in COPD patients. Okay. It means that each breath you take, a larger fraction of it simply contributes to dead space. Okay? And a good way to visualize this is by looking at tidal volumes. Yes,
Does that decrease P big AO2?
does that decrease alveolar O2?
Yeah.
I don't know.
Increase dead space?
It would decrease arterial O2.
Okay.
Yeah. So it would increase the dead space, right? COPD, we're on this side.
Yeah.
Increase ventilation, or ventilation is greater than perfusion. I don't think it would have much of an effect on alveolar O2.
Okay.
So let's say you have a tidal volume of 500 milliliters, okay? And you have a dead space volume, which you're gonna learn to calculate in a little while, okay? Of 150 milliliters, okay?
VB is dead space volume?
Yes, dead space ventilation or dead space volume.
Is that just the volume in the the airways that don't conduct gases?
That's exactly right.
Okay.
Yeah. So, the dead space volume would be the amount of air like sitting in your airways. Okay. If you have COPD, you have dead space disease. So you're going to have an increased amount of air sitting in your chest. You're going to be hyperinflated. And that air isn't doing it. It's just there. Okay. Exerting pressure. Okay. So what is 500 divided by 150? Hope I'm going the right way. Okay, go the other way, then 150 divided by 500. 0.3. 0.3, okay? 30% of the tidal volume that this person breathed in is dead space, okay? It's not participating in gas exchange. Now, what if your tidal volume was 300 milliliters, okay? But your tidal volume was still 150 milliliters, okay? This is calculated off of height. Your height's not gonna change, but the depth of your breath can change, right? What percentage of their tidal volume would be dead space? 50%. 50%. 5 up. Okay? So a greater percentage of that volume you inhaled is just dead space. It's not removing CO2, it's not adding oxygen. Yes?
So the total amount of air went down.
Correct.
So then why on an x-ray does it show up more like darker?
Because the air is trapped in the chest. It's not moving. It's
Oh.
not part of this tidling volume moving in and out. It's stagnant, just sitting in there, unable to be moved.
Okay.
Okay? Does that make sense?
Yeah.
And that air trapping will cause reduced tidal volume because it's physically taking up the space you would need to breathe in that extra air. Okay? So not only do you have a lower tidal volume, but you have a much less efficient tidal volume. when you start taking those small breaths. Okay, elevated airway resistance, raw. You're gonna learn all about raw. You're gonna calculate raw, think about raw. Elevated airway resistance in asthma. So think about it. Asthma is an airway disease. Remember, airway parenchyma, airway disease. The airways in the lungs shrink up on you. Okay? Is it easier to breathe through one of those big old Slurpee straws or a coffee straw? Slurpee straw. Ah, those Slurpees. Frozen Coca-Cola. Oh, the pina colada one's good too.
That's my favorite.
It's the hardest one to find.
Mm-hmm.
What's up with that?
It was at 7-Eleven the other day. I got a big one like that.
Oh, I'm jealous.
Back when I used to drink Slurpees, I liked that one.
Okay. Now, both COPD and airway resistance in asthma cause intrinsic positive end expiratory pressure, PEEP. Okay? PEEP might not mean anything to you now. Okay? But PEEP is going to mean a whole lot to you real soon. Okay? And what that is that's pressure left over in the chest after you exhale. Okay? The pressure that would be left in my chest. Okay? Now, in asthma with elevated airway resistance, these people, kind of like COPDers, have a hard time getting the air out, which leaves a volume of it trapped in the lungs, which leaves a higher pressure trapped in the lungs, which we're calling positive end expiratory pressure. Yes,
Wouldn't that open up more alveoli for him?
potentially.
Okay.
But the problem becomes, if I can hold this much air in my chest, okay? And you and I are sitting here right now, when we exhale, we have this much air left in our lungs, okay? This is our residual volume, okay? Someone who's air trapping, their residual volume is gonna build up. Okay? So you and I, we have all this space to pull in that tidal volume and exhale out that tidal volume, okay? Our air trapping patient has that much space. Smaller tidal volume, less efficient tidal volume, more work. Evan had to say that first.
So what? So that would be air that you've already inhaled previously.
Yep.
That's
Yep.
stagnating in there.
It is just sitting in there, it won't come out when you exhale.
So would that mean that oxygen has already been pulled from it? That would lower P big AO2 on average, maybe slightly.
If you want it to, Evan,
I don't want that
I'll let it.
I don't.
Our concern here is PaCO2.
Okay.
Okay, our CO2 isn't coming out.
Well, I notice when I'm having asthma attacks, usually what it is like my exhalation takes 2 and 3 times
That's
longer.
exactly right. That's that air trapping process. And what you need to be doing is pursed lip breathing.
Yes.
Putting back pressure on your lungs, that's gonna hold the airways open a little bit and allow more volume to escape. All right. Okay, so elevated airway resistance in asthma, COPD, we kind of demonstrated what's going on there, okay? Both of these things, asthma and COPD, are obstructed disease, which means the air will go in relatively easily, will not come out relatively easily, okay? Just gonna require additional work to get the air out, okay? Okay, both of these things, asthma and COPD, cause increased positive and expiratory pressure. Okay, you can also have increased work of breathing due to pneumothorax. Sure, you got one lung collapse down. You gonna be able to pull much of a breath into that? Not so much, okay? That air's leaking out into your pleural space. Now, in 135, the next thing we're going over is x-ray, and then we'll do chest tubes, okay? And we'll talk a lot about pneumothorax. I think I'm gonna ask you, okay? She used to do the training on it over at Covenant. She worked there. She's really good. She's at least be more entertaining than listening to me, right? Okay. Rib fractures. Okay? It hurts. It hurts. The muscles attached to those ribs, okay? They're gonna be pulling when they should be pushing, they're gonna be pushing when they should be pulling, depending on how you fractured your chest, okay? Less tidal line, exactly right. Pleural effusions, again, we're losing volume in that lung because it's being collapsed from the bottom up. Water is displacing where the lung should be sitting, or serous fluid, I should say. Hypermetabolic states such as burns, okay? Your respiratory rate is baseline increased because your body has a massive amount of metabolic activity going on, okay? When you get burnt, you lose your ability to thermoregulate, to hold heat in, okay? So your body is constantly burning more calories to try to keep itself warm enough on top of heal itself, right? Okay. So that can cause increased work of breathing, leading to ventilatory failure. Okay, clinical presentation. Rapid, shallow breathing is indication of impending ventilatory failure. Okay? Rapid, shallow breathing, especially in your asthma and COPD patients. You know why they're taking shallow breaths? Because they can't take a big breath. As much as they want to, they cannot. Okay? This will increase your dead space to tidal volume ratio. That makes each breath less efficient. Okay? Each breath is removing less CO2, which means that CO2 is going to equalize with your blood, and you're going to have hypercapnia. Okay. All right. Diminished breath sounds in young asthmatics is ominous. Okay? You would rather hear wheezing than diminished, because at least wheezing is moving air. Okay? Irritability, confusion, and coma are signs of worsening hypercapnia. Muscle tremors and papilledema. Is that supposed to be papilledema? Papillary. It's in knee, right? Kneecap? I think that's supposed to be pedal. Okay. All right, guys. Young asthmatics. Okay. They're gonna come in. They're gonna have increased work of breathing and anxiety. Okay. They're gonna be breathing pretty quick. If you draw blood gas on them, it might look normal. Okay. All right. Cool. They're compensating, right? Don't let that fool you. They can fail very quickly. Okay, so they can swing from a normal or alkalotic state to a respiratory acidosis quite quickly. Just a matter of when they burn out. And that's when you're gonna see things like Heliox being used to decrease that airway resistance and that work of breathing, to let that patient move a larger tidal volume, trap less air. Not to mention a ton of albuterol. They'll also get steroids put into their IV, which is gonna dilate the airways, okay, as well as some other goodies. And give mag sulfate, all sorts of different stuff to dilate those airways. Okay, so we talked about type 1 respiratory failure and we talked about type 2 respiratory failure. Okay, what's type 1 respiratory failure? Oh my God. Someone better be able to tell me what type 1 respiratory failure is. That's one of the causes, but what is it?
It's a hypothesis.
I see you, Evan. Give me 1 second here. Come on. Sing me a song. Sing me the type 1 respiratory failure song. Come on, what is it?
7.25.
No, that's not respiratory failure.
No.
That's type 2 failure.
Well,
Oh.
What is type 1 respiratory failure?
It's not mucus.
No. Well, I mean, that's one of the things that causes it. But what is it? Hypoxemic respiratory failure. Okay? Your acid-base balance can be normal. Your PaO2 is lower than 60 on room air. You're having trouble with your you're having trouble with your oxygenation. Remember, we're assessing 2 things on our blood gases. What are they? pH, which is our acid-base balance, and what?
CO2.
That's part of your acid-base balance. Oxygen.
Oh.
Acid-base balance is pH, CO2 and bicarbonate. Oxygenation is PaO2. Those are the 2 things we're assessing. So type 1 respiratory failure is hypoxemic respiratory failure, and here's what causes it. 5 things. Okay? So write that down, if you have not already. Type 1 respiratory failure equals hypoxemic respiratory failure equals these 5 things. One of or a combination of these 5 things. I'm gonna give you guys some time to write that.
Basically, anything under 60 told there's one of the 5 reasons why right there.
That's exactly right. You walk in to see your patient. They're sitting there on a room air, watching SVU. And you stick your pulse ox on their finger. Okay? The pulse ox reads 86%. Is our PO2 less than 60?
Yep.
It is. Okay? One of these things is causing it to be there. Okay? Most of the time, it's one of these. Okay? But there's plenty of people out there that have decreased cardiac output. Okay? And the reason that most of the time it's a VQ mismatch is because we'll keep them set. All right. With that being said, what's type 2 respiratory
Hypercapnic.
failure? Hypercapnic respiratory failure, okay? So we looked at our ABG and the patient's PaO2 was 40. Type 1 respiratory failure, check, okay? The patient's CO2 is 60 and their pH is 7.22. Do we check the box for type 2 failure as well?
What happened with the PhD? Okay.
7.22.
Oh, okay, yeah, it's about you.
We'd absolutely check the box for type 2 respiratory failure, which is also ventilatory failure. Okay? Someone who's had to come along and know. Okay. Now, we had looked at acute failure, acute ventilatory failure. Now we're gonna look at chronic respiratory failure, which we've done before. Okay? We've looked at this before. Over months, so this is combined type 1 and type 2. Unless the officer is corrected. Over months and years, acute respiratory failure will become a chronic condition. Body develops compensatory mechanisms. What are they? What's the compensatory mechanism?
Increased bicarb.
Increased bicarb retention. Okay? To counteract the increased CO2 retention. Okay. Compensatory mechanisms for chronic type 1 failure. Okay? Patients will develop polycythemia. Chronic low oxygen level. You're gonna get more blood cells. Okay? So if you're at the Amazon distribution center, it's got a bunch of boxes, okay? And you got a bunch of delivery trucks, but each delivery truck's only allowed to fill up halfway full. You're gonna need twice as many delivery trucks, right? That's polycythemia. Okay, and then we're gonna get an oxyhemoglobin, everyone's favorite thing.
Wait, the right shift, if they decrease?
That's correct. So more oxygen will attach to hemoglobin. Okay. Although it will have a harder time being released into tissue. Cerebral blood flow is enhanced by an increased PaCO2. That's kind of a random fact thrown in there. Has anyone heard the adage, you hyperventilate a head injury? No one? Okay, fair enough. So, to a point it still is, but for the longest time, a head injury within 24 hours is always hyperventilated. Okay? The idea being that you dilate the blood flow, the blood vessels into the brain to allow more oxygen into the brain. Okay? It's not done as much anymore. Okay? But for the longest time, it was a thing. Okay? First 24 hours, you hyperventilate the patient, keep the pH at 7.32. The idea was to try to save brain by providing enough oxygen. Well, it's kind of a double-edged sword because you let more blood into the brain, which increases the swelling, which increases the pressure on the brain. Because the brain's trying to swell up, just like if you smash your thumb in the car door, it swells up, you know? Yeah, your brain's trying to swell up, but it's inside a skull, right? So it doesn't have anywhere to swell to. Okay? It Except for, what's the only hole that your brain moves out of? The foramen magnum. Okay? And when your brain tries to squeeze out that, you hyperventilate and then you die. And that's called a herniation of the brainstem. You'll see the patient. They're dead. Yeah, it's pretty wild. Okay. So, that was chronic hypoxic failure. A couple of things that the brain or the body will do is develop more red blood cells to carry that oxygen around. Okay. Chronic ventilatory failure, hypercapnia, renal response. Look at that, retained bicarbonate. Okay, we just hold on to the bicarb. Kidneys hold on to the bicarb. We got too much CO2, cool. We'll just keep some more bicarb around to balance it out and keep our pH normal. All right, now acute hypercapnic failure, acute ventilatory failure for the 1800th time. pH decreases 0.08 for every 10 millimeters of mercury increase in PaCO2. Am I gonna make you memorize that? No.
I was just gonna ask, is that gonna be?
Okay, and then I think we've seen this before too. Chronic hypercapnic failure, pH decreases 0.03 for every 10 millimeter mercury increase in PaCO2. Okay, so look, chronic hypercapnic failure, you get a little less swing. Okay. Acute hypercapnic failure, you get a bigger pH swing. Yeah.
Is it different because the bicarb would be different?
Yeah, that's
Okay.
exactly right. There's more buffering capacity because there's a whole bunch of bicarb in the system already. All right. Oh, we're taking it down to the wire. All right. Acute on chronic respiratory failure. What do we see in here? What's that mean?
Someone gets sick on top of their chronic problem.
They're already a retainer. They're already a chronic respiratory failure patient. What were we saying earlier about COPD patients and their ability to increase their respiratory drive when the CO2 increases in their blood?
Sucks.
They're not any good at it,
Sorry about that.
okay? So an acute on chronic respiratory failure situation is where you have a CO2 retainer with a fully compensated respiratory acidosis. Okay? Get sick. Okay. Something goes on top of their chronic condition. Okay. What's this blood gas gonna look like?
So,
Not necessarily combined.
it's gonna be an acidosis,
It's gonna be an acidosis.
respiratory acidosis.
Partially compensated probably.
It's gonna be a partially compensated respiratory acidosis. That's exactly right. The bicarb's gonna be elevated, okay? It's an acidosis, so our pH ain't gonna be normal. pH is gonna be low. It's a respiratory acidosis. We're talking about respiratory failure, so the CO2 will be elevated. Does that make sense? Should I write an example on the board? I can do it. Okay. So it looks something like this. 1.31. The bicarb is elevated because the CO2 has chronically been elevated. Okay? The kidneys have held on to bicarbonate to make the pH normal. This person whose CO2 is normally probably in the 50s has gotten sick. Their CO2 has spiked, resulting in an acidosis. Now, look, you can tell what caused this because look, you have an acidic CO2, you have an acidic pH. So it's respiratory driven, but there was a baseline elevated bicarb. Does that make sense?
What do we do for a patient like that?
You're gonna support the ventilatory status.
So, like,
Depending on what's the cause. That's exactly right, yeah. Most of the time, since these are more often than not COPD patients, the front line, the gold standard is non-invasive ventilation, so BiPAP. Yes.
Is ventilatory, the definition of ventilatory failure, is that kind of iffy with COPD patients? Is it slightly different? Yeah.
Yep. Yeah, that definition is with a normal person.
Okay.
And you can have someone like, okay, so a pH of 7.25 and following, okay? If someone has a pH of 7.27 and a CO2 of 49 and rising, guess what? They're in respiratory or ventilatory failure,
Yeah.
okay? Like, close enough. Alright, so you have someone usually with COPD already, okay, they get sick. And most commonly, what causes them to get sick can be all sorts of stuff, a bacterial or viral infection. Okay? They get pneumonia. COPDers are more prone to pneumonia. Okay? Congestive heart failure. Okay? They go into right side failure. Or I'm sorry, left sided heart failure. A PE. Okay? These people are generally relatively sedative. They aren't up running laps, hitting the treadmill. Okay? I mean, some of them are in pulmonary rehab or they're trying to take care of themselves. Okay? Higher risk for pulmonary embolism. Okay? Blood clot floats up from down in the leg, gets pumped through the right heart right to the lungs. PE. Okay. Chest wall dysfunction. Something happens to cause the chest wall to not expand and contract properly. Non-compliant with their treatments. Okay? Don't touch my oxygen. Oh, now I'm hypercapnic because I've got way too much oxygen. And you guys, the non-compliance thing, a lot of the time, it's not on purpose. Like, do you know how many inhalers some of these people have? Like, they're trying to remember what to do what. I can't tell you how many times I've had people be like, yeah, whenever I start to get short of breath, man, I hit that purple one. Works really good. It's like, that's your nightmare. You're supposed to just do that twice a day, every day. It doesn't even start working until you do it for like 2 weeks straight. I'm just kind of like, like alarm bells are ringing, you know, like, okay, maybe try this one next time, you know? And then, you know, a lot of the time, the respiratory medication, the instructions aren't even on the medication, you know? And a lot of people don't know what BID means. They don't know what Q4 means. It's like, why are you putting medical terms on someone's home medication? It's, you know, it's not necessarily their fault. Like, I feel like we kind of let them down sometimes. You know?
A little bit. Like, Google it, stupid. I mean,
No, I got you. But yeah, you know, a lot of times you deal with older people, and they got other stuff going on too, you know?
yeah, you're right.
And they think back, yeah, doctor said, you know, take that purple one, you know, I think, who knows if that's what doctor's for. Sometimes they tell them weird stuff, you know?
Sometimes it's like the explanation for why is too vague, like the CPAP thing.
Exactly.
People are like, that, I hate that, it doesn't help me sleep, but it's like, well, you know what, you need to do it. Nobody
Yeah.
says how it's bad for their heart or explains why it's bad for their heart or
Right.
anything like that.
Right.
I'm always kind of surprised when
I mean, I imagine most
Yes.
people, when they get their home CPAP, is like, I'm strapping that thing on my face.
Right.
But their poor significant other that has to listen to them snore all night, it's like, yeah, you are. You know, and after a while, you know, a lot of people can't sleep without the darn thing. But you're right, like, here's your CPAP, cool.
Right.
Like,
you
why?
need it, it's good for your health. That's
Yeah,
basically what
yeah,
they say.
right, yeah, wear this and your wife won't gab at you so much, okay? It's, yeah,
What's the difference between Q12 and BID?
BID.
Nothing really? Oh, okay, sweet.
So Q12 has to be 12 hours apart, right? BID can just be twice a day.
Okay.
Okay? So maybe once in the morning, once 8 hours later in the evening.
So it could be like 8 a.m. to 8 p.m. or it could be, it just, yeah, it depends,
Yeah,
yeah.
give it to them twice a day.
Okay.
You know, like, I don't know. You give someone a medication at 9 o'clock in the morning, that's BID. Like, maybe they're asleep at 9 at night, you know? Give it to them at 7 or 8. But I suppose optimally, yeah, it'd be about 12 hours apart. Ah, we can get a little more. Alright. So, presence of respiratory, what are we talking about? Acute on-chronic presence of respiratory failure cannot be judged by the normal ABG criteria. Right? But by a significant change from the baseline PaCO2. Alright. So, how do we treat these people? We normalize pH. Okay? What comes before everything? Normal pH. Okay. Avoiding mechanical ventilation if possible. Why do you think that's on the acute on chronic slide?
Make their CO2 normal, then their bicarb's too high, they'll have metabolic alkalosis.
Yeah. I mean, you want to have you want to normalize the pH, okay? Avoiding mechanical ventilation if possible. That's on this avoiding mechanical ventilation part is on the acute on chronic slide because we're almost always dealing with COPDers here. We almost always want to start COPDers on non-invasive ventilation if they meet the criteria. It can be super hard to get them off a vent, so you want to try to prevent it in the first place. Okay. All right, elevating saturation to 90%. Okay, if they're hypoxic, bring them up to 90, but you don't want to take them any higher. Okay. Improve airflow. How are we going to improve airflow? Thinking COPDers. Duono. It's actually right, okay? We're going to reduce airway resistance by providing a bronchodilator, okay? Now we're also going to improve airflow using that non-invasive ventilation, okay? Providing positive pressure. Okay. One of the few times when giving Duono is the right answer. Okay. Treat the infection, okay? This person develops pneumonia. You treat the underlying cause, okay? Monitor and maintain fluid status, okay? That's going to help with cardiac dysfunction. Okay? The first thing we do to someone who's in congestive heart failure exacerbation is diurese. Get them pissing off, urinating off the extra fluid in the body.
I'm recording you.
I know, I'm being recorded. I know. Okay, so we're going to monitor and maintain fluid status. Obviously, we don't want the patient dry. We don't want to get rid of too much fluid, but we do need to get rid of the extra fluid. Okay? Preventing or treating complications as necessary. Okay, that's a little vague. Okay, but if complications come up, okay, we'll take care of it. All right, go ahead and head to lunch. I'll see you guys at 1 o'clock. And